続きまして、EVT レクチャーを開催させていただきます。
Good afternoon. Are you sleepy? Afternoon time. But Dr. Ando make good, ambitious session I hear from him. Please let's learn in English about EVT management for cardiologist.
English? ありがとうございます。So let's start my presentation. Today I'd like to talk about the CLM management for cardiologists. So when you look at this kind of patient, we used to call it CLI. CLI is an advanced stage of lead, and it has been suggested that the mortality rate within 1 year is about 20%. Recently, we call it CLTI. CLTI is a genetic term for lower extremities that are at risk of limb amputation and require therapeutic intervention such as lower extremity ischemia, tissue loss, nerve damage, or infection. So in the U.S., when this kind of patient come to our hospital, so in the U.S., podiatrists manage, control this kind of patient. But in Japan, there is no podiatrist. So that's why the cardiologist could be the key player in foot care in Japan. So recently, the number of debilitating interventions is dramatically increased. So compared to the 2016, the number of the patient is about 2 times in 2021. So when we treat our CLI treatment, so there's 3 big pillars. One is risk management, and revascularization, and wound care. So in the risk management, includes no smoking, blood sugar level control, unloading or decompression, the pain control. In case of revascularization and vascular therapy, bypass surgery, other adjuvant therapies. And wound care include cleaning, debridement, dressing, negative pressure wound therapy, medicine for external use. But many cardiologists think which is the priority. So many cardiologists think the revascularization is the best. However, it's not. The risk management is number 1. The wound care is number 2. The revascularization is number 3. It's the last. So when we treat CLTI, of course the revascularization is important, but priority is not so high. The wound care and debridement, advanced reconstruction surgeries, minor or major amputation, offloading pressure and orthosis, the nutrition evaluation, social support and compliance, perfusion assessment, risk factor modification, smoking cessation, edema control, diabetes management, and infection control. These factors is very important. But in the real world, is there any hospital that has it all? To begin with, the treatment of the chronic wound is super minority in plastic surgery. So that's why it's difficult to form a treatment team for CLTI. But without a CLTI team, you're not qualified to engage in CLTI treatment. So recently, the 2 big articles were reported. So one is best CLI, and the other is Basel 2. So in this article, when we try to revascularize the CLTI patient, in the best CLI, the conclusion is bypass therapy was superior to endovascular intervention in reducing MAIL or death. On the other hand, the Basel 2, the EVT is better than bypass surgery. So the conclusion is carried over. But from the Japanese, the investigator, Dr. Ida, told us the spinach study. In this study, the 3-year amputation-free survival rate was not difficult in endovascular treatment and open surgery. But a very important message is the best treatment option must be selected according to the patient background. So there are many factors which favor for surgical reconstruction, and we have to calculate the number and decide how to revascularize the vessel. So I'd like to talk about the important point to CLA treatment from now on. I would tell TPO. T as a time. The time is the timing of revascularization, debridement, adjunctive therapy, rehabilitation, etc. P as a place, revascularization and wound management according to wound location. O is the occasion, goal setting based on the patient background and wishes. So I will tell one by one. The CLA is not an acute coronary syndrome of the foot. In case of ACS, we go to a cath lab as soon as possible. But in the CLTI, there's a lot to do before going to the cath lab. So first of all, we have to do this kind of things: the pain control, risk factor management, wound care, antibiotics, the drainage. So I will show you the case. This is a shared patient in his 90s, lots of 5, and he was referred by a well-known hospital in Tokyo to my hospital. And in the previous Tokyo hospital, he received the repeated EVT. And the Wi-Fi score showed that he's at high risk of the amputation. So before anything else, drainage is important. The antibiotics is important too, and the rest on bed. This is before the picture of the before drainage, but after drainage, the redness was gone. And 4 days after admission, transmetatarsal amputation was done. And 13 days after admission in my hospital, we performed the EVT and opened the vessel, the posterior artery. After that, 15 days, 25, 43, 70 days, and finally, he discharged after 87 days. And in this patient, I will show you the progress of rehabilitation. First of all, we have rest in bed, and then decompression shoes, and then short leg orthosis, shoe type orthosis, and discharge ambulatory. Key point of this case is CL2I, you should not do EVT cheaply. In this case, the inflammation in the foot had worsened due to inadequate wound management at the previous hospital, and wound care was a priority. Rehabilitation at the right time with the right orthosis and with thorough unloading is important. This is case 2. He was referred to my hospital from University Hospital in Tochigi. So here's the history of the EVT. So 3 weeks ago, the EVT for left SFA stenting, And 2 weeks ago, the left PTA POBA and the left AT was failed. And the transfer to my hospital. And the next day, we performed EVT. So EVT was not so difficult. We restored the blood flow to the intertibial artery. And they get a good result. And the minor amputation was done on the same time, on the same day. So thereafter, rehabilitation was started the 4 days, and after 24 days, doing the heal, and 39 days discharged. What I want to say, CLTI required wound surgery, but the timing of EVT is critical. So of course, the EVT has a high resistance rate. So sometimes we need adjunctive therapy like apheresis or SCS or therapy or ISDN tape. Therefore, EVT and especially below the knee and the surgery are always a set, and the timing is critical. The timing of the rehabilitation, we usually think the misconception that everything is exercise therapy. But in case of CLTI, caution is advised. Absolute rest during inflammation of the foot, a breath that can maintain rest of the wound is essential. They check the worsen of the inflammation after the start of rehabilitation. So we'd like to talk about the place. From the site to nature of the wound, explore cause of the wound other than ischemia, considering the endpoint of revascularization. So when we see this kind of wound, shoe sore or trauma, so in this case, we need footwear adjustment or foot care instruction. This patient has a loss of 4 toe and foot erythema. So not a place to get shoe sore. So we doubt tinea pedis. So we have to check the fungal testing and the treatment. When we look at this kind of patient, the excessive pressure loading due to deformation, so felt and unloaded is very important. And when we look at this kind of patient, so necrosis of the tip of the big toe, the severe cyanosis, so ischemia seems to be a big issue. So, and also we have to make a pressure relieving device. It's very important. So, and to choose appropriate devices. And when we talk about, I'd like to talk about the place. The aneurysm concept exists, but to some extent it matters. Why some extent? So pre-operation, the foster ulcer, but in this patient, post-operation, his foot will be like this. So it's not about the current wound. It's about what kind of surgery it will be. So when we are aware of that, the EVT will also change. We have to open all the vessels. In the case of occasion, what is the goal of the CLTI treatment? Limb salvage, wound healing? It's not up to you. It's up to us. What kind of disease is CLTI? When we ask to the medical staff answer Fontaine 3 was 4, Rutherford 4, 5, 6, something like that. But the patient and family, is it pain? Will I die? Cutting off a leg? Can't live the same life as before? So maybe the patient or family answer like this. So there's the idea that advanced care planning. This is discussing and preparing for future decision about your medical care, you become seriously ill or unable to communicate your wishes. Also, in the ACP, the information from the medical staff and the patient's own wishes, so we talk and talk with a balanced or bidirectional from early on repeatedly. So we provide the information to the patient. It's a very poor prognosis. And also the disease get worse gradually. And clinical cause, it's very pain. We need a repeat intervention or something, and long stay and relapse usually happen. And as a result, ADL down, the cognitive function down, the appetite loss, and it will be the cause of sarcopenia or flare. And even if the wound heals, you will not be able to live the same life as before. We also ask to the patient their wishes. So the patient wishes limb salvage, pain relief, survival, preservation of working function, life at home, or heal quickly. So lower limb preservation is not the only end point. But we can't do them all, so ranking is very important. So the revascularization is also needed. To after asking their patient wishes. So patient hope for limb preservation or for major amputation, for pain relief. What to do is one option. The endpoint of the revascularization varies depending on their purpose. So unthinking EVT attempt for BK lesion are seen. So wound care according to the patient preference, preserve as much as possible. Amputation for pain relief, amputation where it heals first, or amputation where you can talk, so or not amputated. So we have to ask to the patient repeatedly. And if pain relief is a top priority, major amputation should be considered. When considering preservation of the ambulatory function, BK amputation may be superior to Chopard or Lisfranc amputation. So the form of the treatment in accordance with the patient wishes. So the patient sometimes hope the hospitalization or outpatient or home medical care. So if only wound heal is considered, hospitalization is the way to go. But ADL, eating, or cognitive function are better preserved at home. So that's why the education of the caregivers and the expansion of the services is very important to improve the quality of home health care. So in my hospital, we sometimes go to the house survey before discharge of the patient. So, and sometimes advice to the family or patient to do renovation. It's a very important point. So this is the last slide. So the treatment of the CLTI is not a job which can be done in your spare time. If you are involved in CLTI treatment, be fully prepared to get involved. Half-hearted involvement is a sin. Thank you very much.
Thank you, Dr. Andy. Very good.
Andy?
Dr. Ando. Dr. Ando. Good for good presentation. I completely agree with your presentation because maybe 10 years ago, my slogan is act against amputation. So make intervention, and also pediatrics make conference. But limb was salvaged, but the patient's life and the patient's life and their family's life were bad. I treated a lot, and I considered so likely. I make a discussion with social worker and family and nurse. So I changed my strategy for against CLTI. If patient want shorter stay in hospital, I make only simple intervention and refer to orthopedics. But footwear is good. Especially for below knee amputation footwear. But chopard is very bad, in my opinion. How about do you think, Dr. Ando? Chopard amputation. Ankle is very, very weak about ischemia, but it's very difficult to keep weight loss especially for elder patient to educate. Which is better, chopard or below knee?
Thank you, Kaneki.
No, not Kaneki.
Thank you, Kaneki. Yeah.
Thank you.
So, well, of course, it depends on the case. So sometimes the chopard amputation it's very fragile. So it's hard to walk, even though they have orthosis. So in that case, the below the knee amputation sometimes better than the chopard amputation. But of course, it depends on the patient, the case, and we need to have a ACP. Repeatedly discuss about the futures, about the future.
Thank you. JCS recommended ACP for chronic fat failure in several years ago. In my hospital, the Rinkai concerned about ACP and terminal care, not only chronic heart failure, but CLTI, we are now やってます。advanced ACP and terminal care. But one that patient insisted not amputation, but it made very, very bad smell in my hospital or their house. So several trouble has occurred. So how do you treat about the smell in patient's house and home?
Smell. Maybe put a non-smell.
Non-smell?
Non-smell, like a smell retrieving device in a refrigerator. Non-smell. Yeah, I'm not sure. It's a joke. I don't know. So how to prevent the smell? It's very difficult. Of course, sometimes the patient come into my room, the smell is bad, but
so smells back, and the group home and other hospital repeated to refer to hospital. So also pediatrics decided to amputation. It's very, very critical.
Close your nose. Clap your nose. Yeah,
ちょっと英語で言うと難しいんで日本語だけでいいですかね。一回アンプテーションもしない、もう何もしないでくれって言って帰った人が施設に行って臭いからとか家に行って臭いからたまらないからもう一回アンプテーションしてくれって言って戻ってくるケースが several cases I examined.
Yeah, so it's one of the big issues. So, I mean, if the wound exists, sometimes the other hospital or healthcare center cannot receive the patient.
Yes, yes.
So in that case, yeah, of course, in that case, we have to discuss about the future. And in some cases, we amputated as soon as possible and into the below the knee or above the knee, and get a complete healing of the wound and get back to the as a hospital or as a care center, health care center. So sometimes it's that kind of things is needed.
Thank you. Any other question from Flora? Maybe 3 minutes.
Okay, let's finish.
No. But how about maggot therapy? Your hospital, Bad Kaneko, treated maggot therapy.
You are good Kaneko?
Yes.
Oh, really?
I'm a good Kaneko.
I don't know the difference between good Kaneko or bad Kaneko.
How about maggot?
Yeah, in some cases we perform the maggot therapy. It's very helpful.
Oh, helpful. And I confirmed your hospital should be a DPC hospital, but CLTI patients spend a lot, very, very long in hospital time. Maybe
セッション終了まであと3分です。
80 days or 90 days. How do you treating?
So yeah, actually in my hospital there's a room for the I don't know about the technical terms, so I'd like to explain in Japanese. So なんだっけ、
どうします？
心症者病棟があるんですよ。
なるほど。
身体障害者病棟がある。
なるほど。
身体障害者病棟はそこから外れるんです。
That's very good. 僕のうちの病院ないんだ。
だから DPC じゃない。
なるほど。I see. Thank you very much. If very, very important rehabilitation word or 障害者 word. So maybe only 1 minute. One more question? Okay. Thank you for good presentation and lecture, Dr. Andy.
Thank you, Kaneki.
座長、演者の先生方、誠にありがとうございました。